So my name's Anita. I'm a mental health nurse by background, fell into tissue viability by accident in 1999 and kind of stayed there. Love my job, love my patients. So why have a discussion about wound care in mental health? Well, 1 in 6 people in the UK have a mental health problem. One of the census, there's 53 million people. Of that number, 530,000 have a serious mental illness, and by that we mean schizophrenia, bipolar disorder. So that's quite a hefty figure when you think about it. I would say attitudes have improved in the last 10 years towards mental health, but there is still a long way to go, and we do have unintentional discrimination, I feel, that still exists. And for me, no matter what your patient who you're working with, you can only get the best from that relationship if you understand the disease process and can see past it. Unfortunately, some people just see a diagnosis. So, if we think about stereotyping, okay, stereotyping, what does that mean? Well, it's a belief system, isn't it? It's a generalised belief about a group of people. And people believe it's true, don't they? That's why it's called a stereotype. And that's where our unintentional discrimination comes in. The problem with it is, and what we find, is it creates a barrier. And that barrier leads to prejudice. And the GMC have a wonderful term whereby they look at this group of people who are subject to a stereotype and find that every diagnosis after it, every disease process after it, they hang on that label. So it's to do with their learning disability. It's to do with their mental health. That wouldn't happen to you and me. So we need to consider the differences between self-harm and self-injury. Genericists tend to lump these two together as all self-harm, but they are very different. They have completely different drivers. So these are the psychological drivers that we have. We'll talk more about these, but you can see from the slide there are distinct differences as to what will make somebody injure themselves and what will make somebody self-harm. And it's important that we know the differences because our management alters as a result of their drivers. I want to talk about self-injury first. And this is specifically, slide relates to schizophrenia. Now, I love this particular patient just here. I remember one of my TBNs coming in. Anita, can I have a word with you? Yeah, all right, yeah, what's up? I was in clinic yesterday, yeah, and I met this guy and he was telling me that Charlotte Church is his daughter and so Sophie Ellis Bextor. And he's got photos of them that he showed me because he's their dad. Oh, and he was a love god of the 60s in Paris. That's not normal, is it? No. Shouldn't he be in hospital? Why? He's not hurting anybody. He's delusional, yeah, but he's happy. So a lot of these patients, they're not in my inpatient units, they're out there in community. They're in clinics, hopefully. So it's important that we understand what it is about their illness and how it can affect them and their treatment. So it always amuses me, for a misnomer of terms, that a positive effect of schizophrenia is considered to be hallucinations and delusions. It's not exactly what I would call positive personally. Thought disorders, movement disorders. What I want to draw your attention to though, because they're the ones you all know about, is the negative and cognitive effect. So a lot of people will see these patients and say they don't engage. Well, they don't engage because of their diagnosis of schizophrenia. You know, they will have a flat effect. Their face does not record the happy, smiley engagement, eye contact that we tend to have with a lot of our patients. They do find it more difficult to put coherent sentences together. So they're going to have a reduced conversation with you. On top of that, hopefully all of you are out there like me giving treatment options. Well, we can do this, we can do that, these are the pros, these are the cons, da-da-da-da-da-da-da. Fabulous. Except they have a limited understanding to process information. So if we don't take that into consideration, slow down our rate of speech, reduce what we're saying into bite-sized snaps that we can then write down in layman's terms, make an appointment to come back and discuss, you're not going to have that meaningful relationship. They're not going to be able to retain the information. So if you don't write it down in a term they're going to understand, they won't hold on to it. This particular gentleman had DNA'd at vascular 3 times, so he wasn't in compression. And all the way on his records it says not concordant with compression because won't go to vascular. I hate seeing that. You talk to this guy, and actually he has thought insertion from crowds. So the last thing he wants to do is go to a busy hospital. That's why he doesn't go, because of that. But nobody had bothered to find that out. And actually that's easily solved, isn't it? So, bingo, speak to vascular, yep, they can have the first appointment of the day before it gets really busy. With his consent, speak to his community psychiatric nurse. She will go with him to that appointment and support him through it in case it does get busy. He is now in compression. It was great, wasn't it? That's a lovely story, isn't it? Until I tell you that then he stopped going to his appointments. And you think, what is going on? Oh, great. They changed his clinic venue and they changed the day. And he can't cope with that. Put his clinic appointments back to Tuesdays, 10 o'clock, Uppingham Road. He's there every single week, without fail. So these patients, we can't mess around. We need to give them consistency. We also need to give them, and this is very difficult in today's world, double appointment times. Because otherwise we are not going to have that meaningful and holistic relationship. So if you think about self-harm, I think one of the scariest things about self-harm is that the average age of onset is 12. That is grim. The highest rates of self-harm are ages 16 to 24. And if you think about it, social media is a hell of a pressure, isn't it, on youngsters these days. There is no class, age or ethnicity boundaries, so it can be anybody. You actually often see a lot of high-profile professional women in these very high-powered jobs, especially in the very male-dominated industries like banking, who actually self-harm as a means of coping with that pressure. We know that people who do it tend to be very fragile emotionally, simply because they haven't got the learnt coping mechanisms that a healthy child is taught. Prisoners tend to self-harm for very, very different reasons. Theirs does tend to be more of a manipulative form, whereby it is to change cell, get a visit, get a TV. We know that their self-harming behaviours have different drivers compared to people out in the general population. Within the background, you'll find multiple forms of abuse, psychological, emotional and sexual, always there. It is more common in women than men, and there are a couple of reasons for this. One is that you often see it as co-current with depression, and depression is more common in women. But the other is that men tend to release their feelings through extreme sports or fighting, heavy drinking. Mental ill health. You don't have to be mentally ill to self-harm. Most of the people who self-harm aren't mentally ill. Having said that, there is a particular diagnosis within mental health that we see elevated rates of self-harm, which I'll talk about in a moment. And how do you know? How do you know that there's somebody in this room who doesn't manage their emotions through cutting or burning? We don't. It tends to be a very hidden thing. The quotes that you'll see that I put up are actually all taken from the National Self-Harm Network, from patients who actually do cut or burn themselves as a way to manage themselves. And I think it's hard sometimes for us to understand. If we have very good support networks, which hopefully you all do, we talk to friends or we talk to family, but if you can imagine not being able to do that, of having nobody you can turn to when you're very distressed, having no understanding of the best ways to manage that other than to harm yourself, it's a grim thought, I always feel. So why do people do it? It is to release a lot of anxiety and tension that can't be verbalised, as I've said. People use it to talk, to communicate extreme emotional distress. And the interesting thing for me is it's not just about when somebody can't tell you how they're feeling. It's also about when somebody's trying to tell you how they're feeling and you're not actually listening. That's, funnily enough, that is one of the common themes we see in eating disorders. Punishment for perceived guilt. It's really difficult, I think, I find it very difficult, that a lot of these people who self-harm, who have been abused in their pasts, blame themselves for it. Whether that's domestic violence type of abuse or sexual abuse, they will blame themselves, that it is somehow their fault. Looking at gaining control. A lot of this is also around powerlessness, and again, you do see this, another common theme is an over-domineering parent. And a prime example of this is somebody I saw who was busy burning with hair straighteners, which are quite popular with young people for burning. And when I was talking to her, she was basically, she had just finished her A-levels, she'd got her results, and I was asking her what she was going to do with them, and she said, oh, I'm going to go to university and do psychology. I sat there thinking, oh, there's a surprise. I know, that's awful, isn't it? But it's very true. You find that people studying psychology and mental health, in fact, are often looking for answers about themselves. And I said, oh, that'll be really interesting. What do you hope to do with it? Oh, well, I'm going to do my master's then. Right, okay, then what? Oh, well, I've got to do a PhD because my dad said anything less than a PhD isn't worth it. And I thought, yeah, and that's why you're here self-harming. Strangely enough, people do it to prevent suicide. They don't want to kill themselves. And in fact, people who self-harm who do kill themselves, it's either because of an underlying diagnosis such as depression, or if they have a personality disorder, it's usually it's an accident. They didn't mean to actually kill themselves. It's gone wrong. And I think one of the saddest things for me is it's because they can't cry. And we see this a lot more in young men than women. And if you think back to, hopefully, what is becoming a historical attitude amongst men of boys don't cry, be a man. You're not a kid anymore. You're not a girl. You don't need to cry. Actually, we all need to cry, don't we? Sometimes. So mental ill health, the one diagnosis you may come across quite prevalent out in community, there's actually about 16 different types of personality disorders, but the one I wanted to draw your attention to is emotionally unstable borderline personality disorder. And the diagnostic tools we use to consider this is your patient has overwhelming feelings of distress, worthlessness, anger. They can't manage their feelings without harming. They have difficulty with relationships. They act impulsively, severe mood swings, and frantic efforts to avoid abandonment. So if you've got one of these patients in your clinic and this is their diagnosis, you need to be aware of how am I going to manage this so that A, they don't become overly reliant on me, B, they will carry on engaging with healthcare if I'm not here, and C, they have a realistic expectation of when I'm going to discharge them. So all of those need to be taken into consideration. And a prime example of how impulsive they can be is a patient of mine who was very angry with her parents for going on holiday to see her brother in Australia, wanted to make a point when they came back. They opened the door to find her on fire. She had used perfume as an accelerant and it had gone a bit further than she had anticipated, and it had burned her chest, under her arm, her neck. She needed scar release surgery on her neck and she no longer had any hair. That is very impulsive behaviour. The usual causes, genetics, of course, it's always there. Early interactions and coping skills. A lot of you in this room will be parents. And as parents, I'm a mum myself, we try and teach our children, don't we? We give them warmth, love, security, food, shelter, all the basics for them to grow up as healthy individuals. What we find with people with a personality disorder, especially of this type, is some of those building blocks are missing. So they're not there from childhood, so they were never taught how to manage things. And the other thing with this diagnosis is there a very high propensity of sexual abuse in the background. I think, picking up on what you were saying about medics, back in 2004, NICE had to write a guideline for primary care, A&E, paramedics on self-harm. And I thought it was really sad The reason they had to do that was because of the poor attitude that service users found when accessing these services. And that guideline had to be updated. So there is still an overwhelming feeling that people do it for attention. That really is not why somebody does it. Psychosis, on the other hand, we have psychotic depression and auditory hallucinations. So we mentioned earlier command voices telling somebody to do something, but also where you get thought insertion. Paranoid psychosis, we see our patients with these delusional thoughts where somebody can't tell what's real. And obviously with paranoia, people feel they're under attack from somebody. And I suppose you're probably all familiar with the high-profile cases like the Jonathan Zito case is the one that automatically springs to mind. He was murdered by a paranoid schizophrenic by being pushed under a train. So when you're thinking about these wounds, one of the things we need to consider is what was used, because obviously if somebody's used a contaminated blade, for example, you automatically know you're going to be looking at a topical antimicrobial to keep it clean. We need to think about our risk assessment. So if somebody's self-harming and they're also depressed, are they a ligature risk? Because if they are, we don't want to be going around giving bandages. Although to be fair, many of you may be aware, you can use practically anything these days to ligature. Unwise decisions. In mental health, we're quite familiar with the Mental Capacity Act and unwise decisions, and we're okay with that. But my colleagues in tissue viability who are general nurses, my team are all general nurses except me, they find it quite difficult that somebody can actually choose consciously and we're not doing anything about it. It is everybody's right to make an unwise decision. I make an unwise decision when I drink a load of Prosecco the night before I run a half marathon. It wasn't good. But it's my choice. What care has the wound already had? A lot of people who self-harm really look after their wounds. They look after them really well, and they'll say it's the only time they're kind to themselves. But what we have to think about as nurses when they come to us, and if you look at this wound in particular, this is cigarette burns and you can see some here. But if you look at all this scar tissue here, if you press on that, that's really indurated. So it's going to be hypoxic. So that automatically raises the infection risk for your wound. You're also going to struggle with collagen synthesis there as a result of that hypoxia, and then you're going to find it difficult to attract keratinocytes for the wound to close. So we need to include things like that as part of our holistic assessment. We need to think about what medication people are on. If they're psychotic, then they're likely to be on a type of drug called a neuroleptic. Neuroleptics, you might be familiar with the names risperidone, quetiapine, olanzapine, amisulpiride. They're the most common ones these days. All of them affect white cell count. So they can increase infection risk because they've hit your white cells. Underlying conditions, what else is going on with them? You know, are they eating well? Are they depressed? That's affecting their appetite. Are they anorexic? We all know how important nutrition is when it comes to collagen synthesis, angiogenesis, the ability of macrophages to destroy on that very first stage of wound healing. Pain levels, I mentioned that earlier, we have to advocate, because another one that used to be popular in A&E, that hopefully isn't anymore, is that somebody doesn't need pain relief because they enjoy pain. They've done it to themselves, so they must like it. That's a poor attitude. But unfortunately, when you talk to people who self-harm, you do occasionally still find it. So again, we need to advocate for our patients. And the other thing just to throw out there is safeguarding. Because one of the other things is, what are people doing it with? Are the implements left lying around? Are there any blood disorders that they have, like hepatitis, that need to be considered? Do they have children who are witnessing this act? Is learnt behaviour causing a cycle of repeat? So there's lots of things for us to consider as part of a holistic assessment. And we need to think about their healing potential. What is it? Concordance. If you're not familiar with the Mental Capacity Act, please do get familiar with it. It's too easy to write some of these patients off as non-concordant. Repeat injuries. A lot of people who self-harm will go in the same place because it reduces their scarring. What's their nutritional status? We've mentioned that. Infection risk, we've mentioned. Stress. If you've got unmanaged levels of stress, that releases cortisol into the body, higher rates of cortisol, which will decrease your immune function if it's sustained. And if you think about it, people who have unrelenting paranoid thoughts, that's quite scary. And medication, you all know there's lots of drugs out there that affect wound healing. So some of the things we can come up with our patients, we do get strange things put into our wounds. Some of the delusional thoughts cause those strange things to be put in wounds. God is marvellous, actually. A lot of patients, God features a lot in schizophrenia. I'm not quite sure why, but religion is quite big in schizophrenia. Bizarre additives, it's at this point I do like to mention the spitter. So the spitter's one of my favourite patients because he had a burn on his leg. He was in an acute psychiatric unit, and I went to see him because the staff said he won't keep anything on, won't keep any dressings on. So you have a chat with him, which is quite an interesting chat because he is very delusional. And you discover that the reason he won't keep his dressings on is because God needs to see the wound to heal it. So God cannot see the wound if you've got dressings on it. The other problem with all of this was he actually thought his spit was going to heal it. So he would happily gob into his hand and rub it in. So it's just like, yeah, okay, right. So this is where you use your negotiation skills. What will you let us do? Well, he'd let us clean it. Hurrah. So he would have a 4 times a day PHMB soak. And I'd like to tell you that it didn't heal. But blow me, it did. And I am thinking, forget LQD spray, I could go and bottle his spit. No? All right then. But things to think about. You've got medication that you can that nurses will use because people are not going to lose their delusional thoughts, their hallucinations without medication. That's a given. We need to use our imagination and we risk assess. We need to consider, if somebody's removing their dressings, we need to think of the cost and the clinical. And if they don't want a dressing on, then the LQD spray is great and it's antimicrobial. We need to think about limiting access if they have dementia, for example. But also, actually, we need to think about how are we engaging with them to get them to concord with the treatment options we want to provide, because it's not necessarily straightforward. So not removing the pressure is a problem that we get as well. And it's interesting, we do see patients with pressure ulcers and the staff will say to me, I don't know how he's got them. He does nothing but walk around all day. And you'll go, okay, what's he doing at night? Oh, I don't know, he goes to bed. Okay, do you think you can just monitor that for me? And when you get them to monitor what they're doing at night, you discover that the medication that they're on knocks them for 6 and they lie like a plank in bed. So if you do go into mental health inpatient units and you have these patients, it is worth finding out, from a pressure ulcer prevention perspective, what do they do at night? So if we're looking at this client group and we want to manage the wound, what sort of things do we need to consider? So we need to think about what access does my patient require to the wound. Think back to the person with the sterile forceps who was busy harming himself. Because if they want to get at the wound, you can put the most fantastic expensive dressing on it and it's going nowhere, because that's not what the patient is wanting. They are not ready for it to heal. What contamination levels are there with the wound? If they've done it with something that isn't sterile, then it's likely you could end up with a localized infection. If they're continuing to fiddle with it, what are they using? Do they know when to seek help, where to go? We have in my trust, we wrote a information leaflet specifically for self-harm, and it's got basic first aid in it and clinical signs of infection, things like that. Things like that are quite useful to give out. We have to respect their choices. It might not be how we would choose to deal with our emotions and life, but that's how they've chosen to deal with it. And some people, they don't want others to know that they're doing it. We have to be sensitive to that and keep it hidden. And there is something called harm minimisation that you may or may not be familiar with, but that talks through ways to keep people who self-harm safe. And at the end of the day, like I said, it doesn't mean somebody's mentally ill. We do need to make compromises. We do need to look at working with any mental health professionals who are involved, but again, it is only with consent. And reopening it doesn't mean they don't want it to heal. But we do need to look beyond that injury. We do need to remember that the person is a vulnerable adult at the end of the day. And actually, it could have taken a lot for them to seek help, especially if they had a poor experience of health professionals in the past. And actually, do you know what? It's all right if you don't like the wound. It's all right if you find that wound distressing. But what we need to be clear about is that those are our feelings. It's not their fault that we feel like that. And the most important thing, the first thing to say to somebody whose wound you are going to deal with, who self-harms, is that you're not there to tell them to stop. Because one of the things they hear far too often from health professionals is telling them to stop doing it. That's not our role. Our role is to support them with the wound healing if that's what they want them to do. And remember, self-harm, self-injury, whichever one it is that you're addressing, it's symptomatic of an underlying problem. It's not the problem itself. When we have self-injury, we need to think about informed decisions and best interests, and again, Mental Capacity Act. Again, ongoing contamination levels, if you've got somebody who likes to stick their fingers in it, and again, sadly, that's quite common. Oh, and one tip to all of you, because this happened to me, and it was gross. Patient, schizophrenia, on the couch, in the clinic, minging leg ulcer, believes he's a doctor. That's always problematic when they believe they're a doctor, and they're not. I leant forward to sort of not read the right act, but be quite firm. And as I leant forward and I'm talking, this unpleasant finger got stuck in my mouth. So, tip of the day is don't stand too close. This is where I sit there and go, I love my job, I love my job. So, risk assess for further injury. Are they likely to do it again with their levels of psychosis? Respect their choices. If they don't want your dressings for whatever reason, and it may well be to do with God, we have to respect it and look at how we can work with it. Work with what you've got. The websites at the bottom are the 3 I would thoroughly recommend if you do deal with this client group. National Self-Harm Network is run by people who self-harm, and that is a really good one. So things that we could do to improve concordance: simplify the care regime. So remember what I said to you about the leg ulcer patient: same time, same day, same clinic. We need to consider how we provide information. Remember what I said about the cognitive and negative effects that these illnesses can have on people's ability to understand. And crucially, if patients miss an appointment or you can't get access, we need to be following it up, because it could mean that they're in crisis and that we need to alert the relevant GP or mental health worker to get round there. It is worth liaising with mental health if you've got a patient coming in. We had a guy that we had on a pump, discharged from hospital. The nurse went round, and when she hadn't got her scissors with her to open the dressings, he lifted a machete off the wall to cut them for her. So when we rang the consultant, he said, do not go around his house under any circumstances. But things like that are on one electronic system and we're on another. So it is always worth liaising with mental health. Yes. We said allow extra time for appointments, and there are lots of things we can do. We need to focus on the strengths of these people. What I've shown you is some of the difficulties, but we need to value them and we can work with them. We just need to use our imagination. And the last word I would give you on this client group is, when we have students on placement and we have patients to see who have a mental health disorder, or have self-harmed, what impression do we give?